This lesson is about AV blocks. Now before we talk about AV blocks, let's just review the electrical conduction system of the heart. This is the SA node. It is the primary pacemaker of the heart. It produces sinus rhythm and it paces normally between 60 to 100 beats per minute. And this is the SA node. It's a secondary pacemaker. If the SA node is able to pace, the AV node can pace. It produces junctional rhythm, and it normally paces at a slower rate between 40 to 60 beats per minute. Now, if the SA node and the AV node are both unable to pace the heart, the ventricles can pace the heart. It produces what's called idioventricular rhythm, and that paces at a range between 20 to 40 beats per minute. Now, in normal sinus rhythm, the SA node is the pacemaker, and it initiates atrial depolarization, which is represented on the ECG paper as a P wave. Then that depolarization travels down through the AV node, where it's delayed slightly until the ventricles and initiates ventricular depolarization, which is represented by your QRS complex. Now everything that depolarizes has to repolarize, and repolarization of the ventricles is represented by the T wave. Now let's talk just for a second about the ECG paper. Again, there are large boxes and small boxes. Each large box represents 0.20 seconds, and each large box has a number of smaller boxes in it, which equals 0.04 seconds. And to determine the rate of either the atrial rate or the ventricular rate, you can take the number of large boxes between either P to P's or R to R's, and then take 300 and divide by that number. So if there were 300, or if there were 3 large boxes between R to R's, then the ventricular rate would be 100 beats per minute. Okay, so what purposes does the AV node serve aside from being a secondary pacemaker? Well, it serves a valuable purpose in that it slows conduction velocity from the atria down to the ventricles. So why would you want to do that? Why would you want to slow down the conduction velocity? Well, the heart is a pump. Pumps blood through your body. And in your right atrium, you have deoxygenated blood, and in your left atrium, you have oxygenated blood. And when the atria contract, it produces a P wave. And when atria contracts, it forces blood down to the ventricles. So from the right atrium, deoxygenated blood travels down to the right ventricle, and the oxygenated blood in the left atrium is forced down into the left ventricle. So what that delay is doing is it's allowing for adequate time for ventricular refill. So it allows a small amount of time for this to happen. And then when the ventricles depolarize, of course, then your deoxygenated blood from your right ventricle travels to your lungs to get oxygenated, and then the oxygenated blood that's in your left ventricle travels to your body. Which of course represents the QRS. So that slight delay allows for adequate time for ventricular refill. So another purpose of the AV node is to block rapid impulses. Now, what do I mean by rapid impulses? Well, what rhythms have you learned that have rapid atrial rates? Let's just talk about atrial fibrillation. Atrial fibrillation, the atrial rate could be greater than 350 beats per minute, so very fast. So let's just say that your patient is in sinus rhythm. And of course, you can see here there's a ratio of 1:1, 1 P wave for every QRS. So then if the atrial rate is 75 beats per minute, the ventricular rate is also 75 beats per minute. However, your patient converted to AFib. That's my crude drawing of AFib. Now, over here, their atrial rate is 75 beats per minute. But over here, we'll say their atrial rate is 400 beats per minute. So why is your ventricular rate not 400 beats per minute? So your patient's in AFib, and it's generating all these electrical impulses at 400 beats per minute. So what the AV node is doing is the AV node is acting like a surge protector. It is blocking out many of those impulses, only allowing just a few of them through to depolarize the ventricles. So this is really a valuable function of the AV node, because had it not been for the AV node blocking out many of those impulses, when your patient converted to atrial fibrillation right here, they would have also went into ventricular fibrillation, and it would have resulted in death. So the AV node prevents people that go into AFib from AFib being a fatal condition. Now we know that a normal PR is between 0.12 to 0.20. That's normal. That's a normal delay. But what happens if that delay is longer than normal? Well, we call that first-degree AV block. In first-degree AV block, everything happens normally. You're in sinus rhythm, atria is being depolarized. However, the delay through the AV node, it exceeds 0.20. So the PR is greater than 0.20 seconds. All the impulses, it's important to point out, all the impulses are still reaching the ventricles. So if the atrial rate is 75 beats per minute, the ventricular rate will also be 75 beats per minute. Every impulse the atria is generating reaches the ventricles. So that means there is a 1-to-1 AV conduction. 1 P wave for every QRS complex. It just so happens that that delay took longer than normal. So we'll say this is a 0.28 PR. So it took longer than what would be expected. So let's look at an example strip of first-degree AV block. Looks like the rhythm is regular. rate. Let's take a look at the number of large boxes between R to R's. 1, 2, 3, 4, 5, 6. So if I take 300 and divide by 6, that equals 50 beats per minute. PR, let's take a look at our PR. Looks like about there. PR looks like approximately 7 small boxes. And so 7 times, now each small box, again, is 0.04 seconds. So that results in a PR of 0.28. P waves are upright, rounded. 1-to-1 AB conduction. There is 1 P wave for every 1 QRS complex. And the QRS looks to be about 0.08, maybe 2 small boxes in duration. Relatively narrow. All right, so this is an example of first degree AB block. But what happens if that PR is not just elongated? What if that impulse gets blocked altogether? So that's when we start talking about second degree AB block. Second degree AB block is broken down into type 1 and type 2. So we're going to talk about type 1 first. Second degree AB block type 1, also called Winky-Bach, also Obitz 1. So it has 3 names. As if it's not confusing enough to learn blocks already, they gave it 3 names. So in second degree AB block type 1, the important thing to know about this rhythm is that the PR elongates. So it's getting longer. And then the conduction is completely blocked through the AV node. And the process starts all over again. So you can see how the PR got longer, longer, and then one impulse is completely blocked. So in that situation, the SA node initiated depolarization right here. Impulse travels down through the AV node. However, that impulse got blocked. So it did not reach the ventricles. So your heart rate was slowed. It was slower because of that block. But then, the next impulse that SA node fired off, it did reach the ventricles, and that PR reset, and the process may continue again. So the characteristics of second degree AV block type 1, it's irregular. Where this block is present, it will always be irregular. And that's an important distinction. We'll talk about that, why that's so important later. But second degree AV block type 1 is irregular where the block is present. And the rate can be variable. The PR elongates, and the P wave QRS ratio is at least 2 to 1. So you have 2 P waves for every 1 QRS complex. So 2 to 1. 2 to 1 AV conduction. So every 2 impulses that were generated, only 1 reached the ventricles right here. Okay, here is an example strip. I'll give you a minute just to look at that. All right, let's evaluate this strip. Now, first thing on our list here is R to R. Is the R to R regular or irregular? Meaning, of course, is there equal spacing between QRS complexes? It does not look like it. It looks like it is irregular. Okay. What's the rate? Well, the rate between this R to R looks like about 6 large boxes, and 300 divided by 6 is 50 beats per minute. However, it's irregular. So you can't measure the rate simply based on those two R to R's. So there's a couple ways you can determine the rate. You can count out a 6-second strip, so it'd be 30 large boxes, and then count the number of QRS complexes within that 6-second strip, and then multiply by 10. That's one way to do it. 6-second strips are pretty popular. Another way to do it is you can average. So in a situation like this, I have a pretty consistent kind of short, long PR or R to R interval. So if I counted the number of large boxes between this here, looks like there's about 10. So 300 divided by 10 equals 30. So if I average those two together, I would get 50 plus 30 equals 80. And if I divide that by 2, that's 40 beats per minute. So this strip, their patient's heart rate is approximately 40 beats per minute. And that's a result of this first-degree AB block, or this second-degree type 1 AB block. Now, look at this strip, you can see there's one PR interval, there's the second PR interval, and then I see nothing. There's a P wave, but there's no QRS complex. And then there's another P wave and QRS complex, another PR interval, and then I have another P wave, but no QRS complex, and the process starts again. So you can see how that PR is getting longer and longer until that impulse to the AB node is completely blocked, and then the process starts all over again here. And then it gets longer, and then it gets completely blocked again. And then the process starts over again. So let's see, we determine the rates approximately 40. The PR is elongating. And the P waves are upright, rounded. Now, for P waves, for a conduction ratio, we have 1:1 and 2:1 AV conduction. So here I have a 1:1, and then over here I have 2:1, 2 P waves here and here for every 1 QRS. And this is how you identify second-degree type 1. The PR elongates, and the R to R is irregular. It's important to remember that when we get to third-degree AV block. That will help you identify between the two rhythms. Okay, so we just finished up talking about second-degree AV block type 1. The causes for this can vary a little bit. Second degree AV block type 1 is less severe than second degree AV block type 2 normally. Second degree type 1 can result from normal physiological processes. It could be, a young person at rest may have this happen occasionally, or it could happen as a result of straining that can happen. So it's considered less severe normally than type 2. So we're going to talk about type 2 now. Type 2, second degree AV block. The distinction between type 1 and type 2 is that in type 2, the PR does not lengthen. See how the PR remains consistent prior to the block. Now, second degree AV block type 2 could be regular or irregular. In this scenario I just showed you, this is an irregular R to R. However, if you had a rhythm like this, where there was a consistent 2-to-1 AV conduction, you can see how these R to Rs are very regular. Now, it's important to note that if you see a strip like this, that you can't really tell if there was any lengthening prior to this happening. So if you see a patient that's in its consistent 2-to-1 AV conduction, there will be a number of cardiologists that would not consider that a true second degree type 2 because you can't see whether there was lengthening that built up to this. However, if you were to search for strips that are labeled second degree AV block type 2, like on Google, you would come up with just basically consistent 2-to-1 blocks. So it can be a little confusing, but this scenario down here, that would be true second degree AV block type 2. And the rate could be a variable depending on how fast the SA node is pacing and what the conduction ratio is that the AV node is blocking. PR is consistent. Like we just said, the PR does not lengthen prior to the block. P waves are upright. Ratio of P waves to QRS complexes is at least 2-to-1. Just like here, we showed you 2 P waves for every 1 QRS complex. Now let's take a look at an example strip of second degree AV block type 2. Now you can look in this strip of PR. Looks pretty consistent to me. Does not look like it's getting longer. And then you see a P wave with no QRS complex. Now it's important to say that when you see AV blocks, this P wave that's being blocked is not early. Like for example, if it was right here, that would be considered a blocked PAC, which wouldn't be considered a second degree AV block. So you're looking for P waves that are on time that got blocked. So this P wave is on time it should not have been blocked by the AV node, but it was. And looking at the rate of this strip, looks like approximately 7 large boxes between R to R's, so 7 divided by, or 300 divided by 7 is 43 beats per minute. The R to R's are irregular. And the PR is, it's consistent. Looks like maybe 4 small boxes, so I'll say 0.16. P waves, it's like upright, rounded. There's a 1-to-1. Like here is 1-to-1. But over here, it's 2-to-1 AV conduction. And the QRS looks to be a little wide. Oh, probably 3 small boxes, so I'm going to say it's 0.12 for the QRS width. All right, now talked about AV blocks when some of the impulses get blocked through the AV node. But what happens if all of the blocks, all the impulses get blocked? Let's say that AV node, that pathway, is completely closed. Say no impulses get down there. So is that going to affect the function of the SA node? No. No, the SA node has no idea that those impulses aren't reaching the ventricles. It's still going along doing its job, right? Depolarizing the atria. However, none of those impulses are reaching the ventricles. So if no other stimulus paces the ventricles, if the ventricles don't pace at all, then the result is called ventricular standstill. And here's a strip that represents ventricular standstill. So R to R's, there are none. NA. The rate, looks like about 4 large boxes, so it's about, HO rate is 75 beats per minute. But the ventricular rate is 0. PR is NA. There's no PR. P waves, well, that's all that they have, P waves. And QRS is NA. So hopefully, if the AV node, if the conduction through the AV node was completely blocked, something would take over. Some other pacemaker could pace the heart. Well, when you have complete block of conduction through this pathway, what you hope is that, and we call this third degree AV block, when that is blocked. Hopefully one of the redundant pacemakers can take over. So the first line of defense is if the AV node is blocked, the bundle of His can pace the heart. Resulting in what's called a junctional escape rhythm. So third degree AV block with a junctional escape rhythm, the SA node is still pacing the heart, or still pacing the atria, resulting in atrial depolarizations. However, none of those impulses are reaching the ventricles. So the bundle of His in this scenario is able to pace the heart at a slower rate, usually between 40 and 60 beats per minute. And it is pacing independently. Now, if you were to superimpose these images over one another, you would see what you see on your ECG. You would see P waves that have no correlation to these QRS complexes, called AV dissociation. This P wave did not cause this QRS to happen. These are two independent rhythms beating completely separate from one another. So characteristics of third degree AV block with a junctional escape rhythm. R to Rs are going to be regular. That's really important to identify that the R to Rs are very, very regular in third degree AV block because they're not being influenced by anything. It's not dependent on how many impulses the AV node allows through it because there is no communication from the atria to the ventricles. You have two separate rhythms beating simultaneously. And the ventricular rate is usually going to be between 40 to 60 beats per minute. And the atrial rate, we'll say between normal limits. So you would expect it to be, if, for example, if the atrial rate was 80 beats a minute, that would be considered, normal. Now, if the atrial rate was 170 beats per minute, that would not be normal. So we may want to consider other atrial rhythms if that were the case. PR, there is no PR because, like we said before, this P wave did not cause this QRS to happen. So the PR doesn't really mean anything because the PR measures how long it took for the impulse to travel from the atria through the AV node down to the ventricles. But in this case, there are no impulses getting to the ventricles. So we have two separate rhythms superimposed over one another. And in junctional escape rhythm, then the QRSs are usually relatively narrow. All right, here's a ladder diagram. It's much better than the one that I just drew for you myself. Now here you can see in the heart, this line represents what the atria is doing, atrial depolarization. Atrial rate is 75 beats per minute. And this line down here represents what the ventricles are doing. And the ventricular rate, as you can see, is 43 beats per minute. Much slower. Now, that's looking at them separately, but if you superimpose them over one another, down here, that's what they look like in the patient's rhythm. If you were to look at a strip of their rhythm, it would look like that. And it can be very confusing because if I look at this, strip and I say, okay, there's their PR, and then, their PR got really long, and then it dropped a beat over here. See, I might think that this is second degree AV block type 1, right? Because it looks like the PR is getting longer. However, let's just erase that so we don't get confused. However, these rhythms, the atrial rhythm and the ventricular rhythm, they're dissociated. There's no correlation between them. And the way to tell between second-degree AV block type 1 and third-degree AV block with a junctional escape rhythm is that one very important characteristic. Second-degree AV block type 1 has an irregular R to R, where the block is present. And here you can see this R to R is very regular, which means it's not being dependent on how many impulses the AV node allows through. It's two rhythms beating completely independently of one another. So this is a really important characteristic because people get second-degree AV block type 1 and third-degree AV block with a junctional escape rhythm mixed up frequently. But the defining characteristic is the regularity of those R to R intervals, because that tells you that there are two things beating completely independently of one another. Okay, here's a strip to evaluate. Let's take a look at this. Now, is this second-degree AV block type 1, or is this third-degree AV block with a junctional escape rhythm? Let's look at the R to Rs. R to Rs look very regular to me. Now the rate looks like there's about 7 large boxes between R to Rs. So the ventricular rate is about 43 beats per minute. However, let's take a look at the atrial rate. There's a P wave. There's a P wave. Looks like there's about 4 small boxes. So that means the atrial rate is 75 beats per minute. PR, well, let's just establish what rhythm this is first. So we have narrow QRS complexes. We have a regular R to R. We do not have a consistent PR. You see, there's no consistency here at all. So is this second-degree AV block type 1, or is this third-degree AV block with a junctional escape rhythm? Well, since we know that second-degree AV block type 1 has an irregular R to R pattern, then we know this strip must be third-degree AV block with a junctional escape rhythm. Okay, so let's talk about third-degree AV block with a ventricular escape rhythm. Now, third-degree AV block with a ventricular escape rhythm means that that SA node can't pace the heart, the AV node, the bundle of His, can't pace the heart. So the only thing left to pace the heart are the ventricles, usually between 20 to 40 beats per minute, much slower. Now this rhythm is also going to be very regular because it's independent of the atria. The atria is still depolarizing. However, the ventricles are left to pace by themselves. And ventricular rhythms are very wide and bizarre. So very regular, but wide QRS complexes. Wide and slow. So you're going to have AV dissociation with this also. Okay, here's an example strip of third-degree AV block with a ventricular escape rhythm. It's pretty similar to third-degree AV block with a junctional escape rhythm, only these QRS complexes are wide and bizarre. You can see we've got our P waves here, 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 here. Oh, there's one that's going to be hidden in here somewhere. There's another one here, here, and there's one up there. Now R to R is regular. Looks like the atrial rate, looks like there's about approximately four large boxes between R to R's, or P to P's. So looks like their rate's about 75. Atrial rate. Ventricular rate slower. Looks like about 7.5 large boxes between R to R's. So looks like about 40 beats per minute. PR is NA because this P wave did not cause this QRS to happen. They are completely two separate rhythms that are superimposed over one another. And the QRS width is, looks like about 5 small boxes. So I'm going to say the QRS width is about 0.20. Okay, let's take a look at some real strips. Let's take a look at this strip and evaluate it. This happened on a real patient. You can see, looks like I have a QRS complex here, and here, and here. But I don't see anything past there. All I see are P waves. So what we're looking at is an onset of ventricular standstill. This is probably these are probably ventricular escape beats here, followed by ventricular standstill. So the patient's heart is no longer beating. Only the atria, which is not sufficient enough to provide the heart to beat sufficiently. All right, here's another practice strip, or a real strip that happened. Take a look at this strip. See a PR here. PR is elongating until it gets completely blocked. And the process starts again until it gets completely blocked. So the PR is elongating, and then the impulse gets completely blocked through the AV node. So this is an example of second-degree AV block type 1. And we can see also that the R to R's are regular, so we're not confusing this with a third degree with a junctional escape rhythm. Okay, here's another practice strip. So let's see if we can identify what rhythm this is. R to R's. Are R to R's regular or irregular? They look pretty regular to me. So immediately I can tell this is not a second degree AV block type 1, because second degree AV block type 1, the R to R's are irregular where the blocks are present. Now, is this second degree AV block type 2? Well, second degree AV block type 2 has a consistent PR. Let's look at these PRs here. Look at that one, compare it to this one, compare it to that one. It's definitely not consistent PRs. Okay. Now where are our P waves? There's a P wave there, 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 there. There's one there. Looks like there's one hidden in here somewhere. There's one. Let's see one after. Atrial rate looks like about 3 large boxes between R to R's, or between P to P's. So it's about 100 beats per minute. It's pretty normal. So this looks like third degree AV block. So let's see what's our ventricular rate? 2, 3, 4, 5. So there's 6 large boxes between R to R's. So 6 large boxes, 300 divided by 6 is 50 beats per minute. So I'm going to say that this is, based on the rate, that this is third degree AV block with a junctional escape rhythm. Based on the regularity of the R to R's, based on the fact that we have AV dissociation, and distinguishing this from, say, third degree with a ventricular escape rhythm, the rate of the R to R's, of the ventricular rate, falls within that of the second degree AV, or the third degree AV block with a junctional escape rhythm. Okay, here's another real strip. Let's see if we identify our P waves. There's a P wave. There's a P wave. There's a P wave. Kind of hard to see. And there's a P wave, and there's a P wave. So it looks like our R's are irregular. Our PR looks like it's lengthening. And then we have a dropped beat. So it looks like 2-to-1 AV conduction there. So what rhythm does this look like? If we have a PR that gets longer, 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 followed by a drop beat, followed by a blocked P wave. I'm going to say this is second degree AV block type 1, because type 2 would have a consistent PR, which this does not, and if it was third degree AV block, there would be clear AV dissociation, which we would see, which we would know because the R to R's for a third degree AV block would be very regular. And here's our last strip. Let's take a look at this. R to R's, appear to be regular. So if our RRs are regular, what can we immediately eliminate? Second degree AV block type 1. So then is it either second degree type 2 or is it third degree AV block? Well, second degree type 2, the PR is consistent. So do I have a consistent PR anywhere? No, not at all. So it can't be second degree AV block type 2, which leaves only third degree AV block. So it's third degree AV block and either has a junctional escape rhythm or a ventricular escape rhythm. Now the large boxes between R to R's, what do we have? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Oh, so we'll say approximately 10. So 300 divided by 10 is 30 beats per minute. 30 beats per minute falls well within the ventricular pacing range, and the QRSs are wide and bizarre. So this looks like third degree AV block with a ventricular escape rhythm.